Good afternoon and welcome to the last of the four-part Medicare Bootcamp series. This convenient and educational session is hosted by Region 10 chapters of HFMA. The topic for today's session is CMS edits and ANSI standards, and we are scheduled to run for 90 minutes. I would like to welcome our guest presenter for today's webinar, Seth Avery, President and CEO of AppRev, which is a healthcare business intelligence company that provides revenue cycle solutions for hospitals and physicians. Mr. Avery has over 25 years of experience with government, for-profit, and not-for-profit healthcare providers, and is a frequent speaker on topics such as denials management, the ICD-10 transition, ICD-10 implementation, charge capture, and strategic pricing. So without further delay, I will hand the call over to today's guest presenter. Mr. Avery, please go ahead.
Hey, thank you very much for taking your time today to sit through this presentation. And as Christine said, please submit your questions as we go through the presentation. So as you think of things, send them along. If we cover them by the end of the presentation, then we can deal with anything that hasn't quite been covered or not to the level of specificity that you require. We will not go for 90 minutes, I guarantee that. If I talk about this for 90 minutes, I may be suicidal, you may be suicidal, but certainly it would be too much for our brains before we would explode. So I'm going to go through this topics, and of course, I've done this presentation a number of times for HFMA, and I'm always looking to improve it. So as you go through it, if you think of things that you would have liked to have been covered in this, and we didn't cover it, please let me know. And also, if you have follow-up questions after the presentation, you can always send me an email also. But with that introduction, again, here we go. So we're going to talk about a couple of things that I have found over the years that many people at work in practices and hospitals, they have an understanding of it, but they don't have a deep understanding, and they don't necessarily know the source of truth for some of these topics. So we're going to talk a little bit about that. I've got some links in the presentation that you should be able to follow. If any, they should all still be good links. If any of them are broken, please let me know, because as you know, a lot of these websites are constantly changing things. So I'll be happy to update them if anything doesn't work. But the last time I checked them all, they were good. So we're gonna have some discussion about this, talk about this, and then there's in the presentation itself. Once again, there's some links for the source information, which I think it's always important. You know, certainly as a lawyer, we're always interested in primary source of the truth. So we're talking today a little bit about National Correct Coding Initiative, NCCI. Some people refer to it as CCI. We're going to talk about the OCE, or Outpatient Code Editor, MCE, which is a Medicare Code Editor. We'll talk a little bit about 837 standards and a few other topics. There'll be a couple of poll questions as we go along. That's as much to keep you guys awake as we go through this presentation as anything else. Okay. So typically, your billing system will have in it the NCCI, OCE, and MCE edits resident in that billing system. But the struggle that I quite often see in hospitals and practices is really knowing what that edit is telling you, and therefore knowing really what the correct action is to either fix the edit and allow the charges to go appropriately through, or to remove whatever the service is that's creating the edit. And again, a lot of people have these edits. They have staff working on these edits, but you want to make sure that you understand what is it that you're actually trying to accomplish to respond appropriately to the edit. So a couple things I put in here real quick is just to look at that. That to be able to analyze the edit and take the appropriate action, it may require a review of the clinical record to ensure that the appropriate service was captured and is indicated in the claim. Also, it may require that you remove that service, because as we get into talking about some of these edits, some of them it's just not appropriate to bill based on the combination of service. And it may require a modifier to provide additional information to the editor so that they know that you appropriately billed or claimed that service. And we'll go into more detail of that. Okay. So NCCI, been around now for 20 years, and it's based on really CPT conventions, and you know, basically this is the logic of it: standard medical surgical practice, national local edits, and guidelines are developed by various societies like pathology, emergency medicine, different groups that have had input to the national practice initiative. We're trying to accomplish. Well, it was started in with physicians in 1996, and then the next rolled it up to the hospital in 1997. And then medically unlikely for MUEs were added in 2007. Most people probably don't know that MUEs are part of the National Correct Coding Initiative. So there's three component NCCI. You have column 1, column 2 edits, which they changed that name like, I don't know, 50 to, it used to be comprehensive, but now they're referred to for some examples. What we have is mutually exclusive, and then the medically unlikely events, which are the three pieces of NCCI. Are what we call procedure to, because as you'll notice at my slide here, if you don't have acronyms here, then it's just not good progression. So we've got G, HICS, and PTP, some good on this page. So procedure to procedure edits, one HICS or CPT on the claim to another to determine if it was appropriate for both of those services to be used on the same claim. And again, I'll give you some examples. Put out first a poll question, again, to keep you guys engaged and thinking about it. The get all started on the screen there. The question goes like this. It goes, with 9 modifier. First answer is, when a service was performed on a separate site, when a service was performed on a separate session, there's a status modifier of 1, and when you want to get paid. So 4 different answers. And again, if you don't have a coding background, this may be a little bit outside of your wheelhouse, so to speak. But we'll give you guys just here half a minute or a minute or so to answer. I mean, think about this carefully. This could determine your future in healthcare. But the 59 modifier, as we get into this, is an interesting modifier that I find a lot of times people really don't understand when to use it, when not to use it, etc. So are we going to publish the poll answers? So most people answered, let's see, you've got a separate site, separate session, and there's a modifier status of 1, and 4 when you want to get paid. And really, the correct answer is a combination of all 4. And if we could close the poll real quick, let me explain my my answer to you, so you just don't think. So the 59 modifier, and again, I'm going to go through a little bit more explanation, really disables an edit. So we need to figure out when it's appropriate. The NCCI was designed to eliminate bundling. It requires providers to bill the most comprehensive service. So let me give you an example. I always like to use wound and wound repair, wound debridement. All those are great examples for NCCI. let's say you have somebody comes into the emergency department and they've been on a bicycle accident, and they basically hit the turf, and if you've ever hit that asphalt, you know that asphalt is just like landing on a bunch of saw blades. It's very hard on the skin, right? So you might have multiple wounds on the back, all of which may require debridement. They may require somebody getting in there, either taking some skin out or taking some rocks out or whatever's in the back. And then some of them may require repair. When we look at the surgical code, and I'm just going to flip on here to the next one, we look at one code may be debridement and one code may be repair. And in the NCCI edit, it expects that if you're doing the wound repair, that if debridement was required, you would also do debridement, and the more comprehensive code would be the skin repair. Basically doing a suture, repairing the skin, closing it, etc. So CMS says we're not going to pay you separately for debridement unless that's the only thing you did. Or in this case, where you might have multiple locations on the body, and that's that anatomical modifier we're talking about. In that case, we can indicate with the modifier that it's multiple sites, which was one of your answers, and therefore we should be paid multiple times for the service. So the first thing we're going to do is in NCCI, we have what's called the modifier status. If the modifier status is 0, what that tells you is you can put whatever modifier you want in this claim. When CMS compares in the OCE, those two code pairs, it's going to reject and not pay the second one. And it's going to pay the lesser of the two. Now, let me make sure I get my memory right. Yes, I'll check that. I hadn't even thought about that in a while. But I'm pretty sure that on that it pays, I'm pretty, and I'll go back and check. One pays lesser of, one pays more, the higher one. But again, it's going to reject it. If it has a modifier status of 1, what that says is this payment flag may be disabled with an appropriate modifier. So a modifier could be, for those of you who are familiar with coding, it could be toes, T1 through 9, fingers, F, etc. It could be different eyelids, left, right. These are anatomical modifiers. Well, in our example of a guy falling off the bicycle and hitting his back on the ground, you only have one trunk of the body, right? So there's no anatomical modifier that's appropriate. So in that case, if we had separate sites, one we did a debridement, one we did a skin repair, and we wanted to indicate to the payer, in this case Medicare, that these were two anatomical sites for which I don't have an anatomical modifier, that's when I actually use the 59. So I have to meet the clinical requirements, I have to meet the modifier requirement, 0 or 1, and then I'm able to disable the added appropriately with 59. Okay, that was actually the longest explanation of the 59 modifier you probably had in your entire life. But that's basically how it works. So what does this tell you? What this tells you is if the modifier status is 0, putting the 59 on it is only, in my view, drawing the attention of auditors to you. If an auditor wanted to look at how often you use the 59 modifier and you're constantly using it on things that it has 0 impact, I just feel like you're just drawing attention to yourself. But again, if people have questions or comments about that, I'd love to hear about that. So what I did was all of the NCCI edits, again, are generally available in your billing systems, but they're also available on the CMS website. So you can go and pull them. They come in a very large Excel file, and then you can actually see the column 1 and column 2. Then you can see the modifier status in there. And very critical item in here, if you start looking at these Excel spreadsheets. They leave them in here even if they have a deletion date. So if they have a deletion date, They're no longer effective, but they're going to still be in these lists. So make sure that you note the deletion date if applicable. Okay. Just a review there. So all your in the CPT manual, Appendix A, you get your HCPCS modifier section. Make sure if you're a hospital, you're using modifiers approved for ambulatory surgery or hospital outpatient use, because they are slightly different than ones available for the physician. And off the top of my head, if you think about it, I'm sure there's some coder out there that's going to correct me if I get this wrong. But, for example, a discontinued service for a hospital, I believe, is 72, and I believe it's 52 for the physician modifier. 72, 73, 74, something like that, in that range. Those are all different than the 52, 53, if I remember, for the physicians. They basically have the same verbiage, just different modifiers. Make sure you're looking at the right modifier section. Getting back to this 59, so in 2015, CMS looked at this issue, and they determined that there were 11 billion in line charges billed with the 55 modifier, with a projected error of 450 million. So this is basically 450 million in charges that were billed where the 59 had no impact because it simply couldn't disable the modifier. And you say to yourself, why would there be a modifier status of 0? There are a number of code sets that, for whatever reason, when they developed these guidelines, they felt like there was no appropriate clinical instance where those codes should appear and be paid separately. That's why the 0 appears. And you'll see a lot more of that in the mutually exclusive edits also. Okay. And there were a number of changes made in 59 modifier to expand it. So we came up to 4 different codes that or modifiers you can use in the instead of the 59 that give a lot more, I guess, granularity, more explanation as to why you're trying to override that edit. Okay. And let me go back 1 second before I move on to OCE. On the mutually exclusive, again, they look just like the column 1, column 2, but the mutually exclusive are a slightly different take on correct coding. The mutually exclusive look at 2 services that I just don't think you would typically do together. And let me give you an example. So if you're doing a skin graft on somebody's leg, it's not generally expected that you would use 2 different materials, which require 2 different CPTs to indicate the material. So if you do an allograft and a laminate graft on the same claim, that's going to pop up as mutually exclusive services because in the estimation of the clinical experts, it's unlikely that you would have done those with 2 different materials. So I'm going to edit that out and say that that is a medically mutually exclusive. You don't do, if you do allo, you don't do laminate. So that's how those codes work. And then the medically unlikely events are the, and you guys have dealt with these, thousands of these in the RAC audits, because the MUEs generate RAC audits, and there are things like an MUE, there's an MUE that says you only get paid for 1 transfusion procedure in a day, because it's a medically unlikely event that you're actually going to start 2 separate transfusions on the same date. There's other examples of MUEs, but that's always one that comes to my mind. Okay, and again, as you think of things about coding as we go along that I didn't cover when it came to the NCCI, please just send a question, comment. Always looking for improvement to this presentation. Okay, OCE, Outpatient Code Editor. So the OCE came out in October of 2000 when we implemented the outpatient prospective payment system. But it does apply to facilities, whether they fall under OPPS or not. An example of that would be like a cancer facility or children's hospital that wouldn't necessarily fall under OPPS, one of those 7 recognized facilities that don't, aren't subject to IPPS or OPPS. But from an edit perspective, it does apply. What it does is it indicates on a numbering system, and the last time I checked, and again, I put the link in here, last time I checked, there were 78 edits. When I started doing Medicare educational programs in 2003 or 2002, there were 40 edits. Since then, they've added 38 edits to get up to 78. And some of them, when you start looking at the list of them, they're going to be very obvious. And they're going to be things like your OCEs. I think your OCEs are 39 and 40 are the numbers on those edits. So you're going to see those invalid codes, things like that. They're going to show up in that list of 78. For each one of those edits, there's going to be two possible outcomes based on that. And one is RTP, where the entire claim is rejected. So for each one of those edits, it's going to have an edit status. It's going to say either RTP or LIR. LIR is just that line that the edit is applied to. Is going to be hit by that. It's going to let the rest of the claim go through. You're going to line on and rejection. So RTP and LIR. Again, when you're working the edits, you need to understand which is which. Whoops, went a little bit too far. NCE. Oh, let me back up again. 1 second. OCE, if you follow that link, again, you should get the list of the current OCE edits, the logic. There's actually a schematic in there. I have in past actually figured out billing issues by following the schematic of the OCE and actually how it works. There's a second file. So for all you data crazy people out there, when you submit those claims, they go to the OCE. The OCE puts payment flags on lines. The payment flags on the lines then go to something that's called the pricer, and the pricer is what actually tells the Medicare contractor what to pay you and in what instances to pay you. So there are times when it's useful to know the logic of how the OCE flags it. It goes to pricer, how it works, and then the other piece of logic that's working behind that is really, the other piece is the common work file, which is the file that holds all the information on your Medicare beneficiary. So if you think of this, the interaction between the common work file, the OCE, and the pricer, let me give an example. So, I'm just going to guess that I still remember how this goes, but like mammography, screening mammography for women, again, don't hold me to the limits now, but I believe it's at 50 and it's every 5 years, but I could have that wrong. I don't remember the years now. But what would happen is the coding would go through the OCE, it would get flagged for payment, and it would go to the pricer, but it would look at the common work file to see when was the last time you had that service performed on that beneficiary, to then see if it fell within the guidelines from a timing standpoint and decide whether it was going to pay or not. So all three of those work in conjunction with your Medicare beneficiaries to determine the appropriate payment status. So OCE, pricer, and common work file. And the common work file is common because, remember, it's getting claims from physicians, other hospitals, facilities, etc., because that mammography 3 years ago may have been performed in an entirely different place. So again, you need to have that common work file to have that single repository of collected information on each one of your beneficiaries. And if you understand all three of those and what I explained to you, I'm sure at the next dinner party you go to, if you try to explain this to somebody, you'll be the hit of the evening. Okay. MCE, Medical Code Editor, or Medicare Code Editor, excuse me, is your oldest edit set still in existence for Medicare. So you have to remember, this started in 1983 when the inpatient prospective payment system was first rolled out. When MCE came out, if you think about it, a lot of people weren't even billing electronically. People were sending paper claims, et cetera. So a lot of this information gets entered. So it's very, very basic edits to try to make sure that the DRG is correctly assigned and appropriately assigned to the right patients. So you have three types of edits, basically, that are covered in this. The code edits, the coverage edits, and the clinical edits. So code edits, this is not any more complicated than looking at diagnosis and procedure codes and looking for consistency and looking to see if they have a logical relationship to a patient's age, sex, diagnosis, etc. So are you doing a procedure that belongs to males on a female? Are you doing a procedure that would be on a mature woman on a 3-year-old? And again, it's editing, going through that to see if there's a logical relationship and then popping out those edits. You should have these edits. All the hospitals should have these resident, again, in their system. And where these pop, in my experience, is when somebody puts in the wrong diagnosis code or the wrong procedure code. Or when I say the wrong one, it's been abstracted to the wrong account. So a lot of times it was coded correctly, it's just on the wrong account, it goes through and it pops, each one of these will pop that way. Coverage edits. Again, this is looking at is a certain service covered under the Medicare plan, et cetera, is a non-covered service. And then clinical edits, these are a little bit more nebulous. I do not always have a good handle on the clinical edits, but let's just say for sake of discussions, they're more like medical necessity. Although there's technically no true medical necessity on Medicare inpatients. So the MCE, again, starts with a very basic set of information that comes across, and it's actually the same information that you need to group a DRG. For all of those of you who have done actually MSDRG grouping, you know that you need age, sex, discharge status, diagnosis, procedure code, and discharge date. So you need age because there are certain diagnoses or certain MSDRGs that only belong to certain age groups. You can't, there are some that are for younger people, older people. There are very sex or, the term is sex or gender specific DRGs. And discharge status, there are actually a handful of DRGs that are determined based on the discharge status. And the only ones that I know of involve neonates. And so you get a different MSDRG depending on whether the child was discharged alive or not. So discharge status can matter. And of course, you all know that the diagnosis codes and the procedure codes are driving the MSDRG assignment. And the reason you have to have the discharge date in there to figure all this out is because you have to know which group or year you're going to select. Because if you think about it, if you have a patient that is admitted in September and discharged in September, you could get a different discharge DRG than if they were admitted in September and discharged in October because of the changes in the fiscal year. And this all comes from the Medicare Claims Processing Manual, Chapter 3, which is the inpatient, and then Chapter 4 is the outpatient, but I gave you the link to that specific regulation. Okay, now, poll question number 2, there it is. Is there a different claim format for inpatient and outpatient claims? I'll take a sip of my tea and let you guys ponder that for a second. I have to tell you, for those of you who have not actually conducted a webinar yourself, it takes a little bit of practice. I do a lot of public speaking, but a webinar is interesting because you're essentially talking to yourself for 45 to 50 minutes. So you really got to listen to your own voice to do a webinar. So I think I actually tricked you guys up a little bit with this question. The question was, is there a different claim format for inpatient and outpatient claims? And actually, there's not. There is a different claim format for an institutional versus a supplier. And people cringe when I say this, but I just read it out of the regulations. A physician is a supplier. So you have an 837I is your institutional claim, and that's going to cover your short-term acute care, long-term acute care facilities, your DME, physician services, home health, infusion, all of those things are going to be on an 837P, which is a professional. So those where you get. So hospital institutional, inpatient, outpatient goes on the same claim. So I did probably trick you a little bit in that, so I apologize. So there's your answer. ANSI 837I, 837P, 5010 is the current standard. Whoops, sorry, hit that one too fast. If you're not familiar with the claim format, I gave you a link that's really kind of a nice little walkthrough on that. I find that people who think of the claims tend to think of them in the paper format. So that would be the UB, what is it, the UB04 now, as the paper format, and they tend to think of like the form locators. And actually the Medicare, if you go to that Claims Processing Manual, Chapter 25, it still has references to the form locator, which are basically the fields on the paper form when it goes through this. And then, of course, the professional would have been what we would refer as the HFMA 1500, although HFMA hasn't been the term for a number of years. But again, go through that little bit of introduction. I think you'll find it educational. A couple other things we're going to talk about on the ANSI 837 that might be interesting to you if you're not familiar with them is condition codes, revenue codes, HCPCS, admission source, discharge status, patient status, and impact of ICD-10. And many of these code sets are actually maintained by other organizations. So, for example, the National Uniform Billing Committee maintains many of these. That's where revenue codes come from. They all get together and make very informed and wise decisions about what a revenue code is. And again, the Medicare Claims Processing Manual gave you the link here, which would go through, you could go down, I think it's Chapter 25 actually goes through the claims. So question number 3 of the poll, again, trying to keep you guys interested, staying awake. And actually, we, again, have had spectacular attendance for this webinar. I chalk it up to many people coming back from last year because they didn't understand anything I said because I didn't make any sense. So they probably came back to try to listen to me again explain this. So I'll try to do a better job this year. Okay. Is a description of the service or charge required on the claim? So you got a 50-50 shot here. It's probably going to be your best odds of the day. Okay, so how did our poll stack up? Well, most of you got this absolutely right. Claim the description is not a required field in the ANSI format. So what that tells you is your payer is not paying based on description, right? They're either paying based on a HCPCS code, a charge, a DRG assignment, or something like that. But many of you need your description for a variety of reasons. One, it keeps your staff sane because they're looking at it instead of just the charge code. And two, a lot of times that description is what flows through to your statement. So in many instances, that description is really for the patient's statement and maybe even the EOB that it comes across from the payer also. So that's quite often why we have a description. Although historically, when we were out there printing these forms, I'm sure they made much more impact than they do today. Okay, so moving on from the poll. Talk a little bit about condition codes. So when CMS went to the ANSI 837, it really gave a tremendous amount of power and flexibility to that format. That format is insanely complex and has a lot of power to it that still we really don't tap into. And And these codes are actually on the paper form, but I always feel like they just mean more if you can process them digitally like this. For those of you who have not read it, the guidelines for implementing E47 is about a 625-page document. And so just gives you a real feel for what this format, especially the 5010, can do to make your job easier and more complicated at the same time. So condition codes are things that are specific to an admission for a patient. And they're going to trigger certain things in the Medicare system. So for example, if you put 02 in a condition code, that tells Medicare that this is a employment-related condition. Which, what would that tell you? You know, certainly Medicare is not going to be primary, and it's collecting that information. Here's what it also does, I think. I'm going to have a theory here. You guys tell me if I'm wrong, but I think it's also telling Medicare that this may be a patient that may have insurance other than Medicare. Because there's, most people, I don't know if you know this or not, but Medicare actually syncs up every year its files with the IRS. And the reason they do that is they're actually looking for employment of Medicare patients to determine if it's possible that they have primary insurance that Medicare is not aware of. So there's a lot of that goes on behind the scenes for Medicare to quite justifiably and reasonably determine, just like any other insurance payer in the United States would do, to really determine if they're in fact the primary payer. Another code I threw in here as an example, because you know, for those of you who work in hospitals that have a lot of hospice patients coming in and out, you know how complex it is to ensure that you are correctly billing, or I should say appropriately billing for services for hospice patients. So, and here's an example of an occurrence code. So occurrence codes are typically, so condition codes are driven to an episode of care. Occurrence codes generally go to dates. So for example, if a primary insurance other than Medicare was actually terminated while the patient was under care, you would indicate that with the 25, and then Medicare would know at that point forward that they become primary or possibly primary. Another example I put in here is related to when you have developed or last reviewed or established a physical therapy plan, which is required. And again, some more references in here to the Medicare claims processing guide, and an example of, and I'm sure many of you see these all the time, each Medicare administrative contractor, or MAC, should put out its own billing guide. Many of them do. Some of them are just really quite helpful. But remember, they are not a definitive source of the truth. They are what we would call in law a secondary source of the law or information or regulation. They're not a primary source. Okay. So I went through that in about 40 minutes, which is probably a little bit quicker than I normally do. But now, if you guys have some questions, I look forward to any of your questions. And we can go
Okay,
from there.
thank you.
Right now,
thank you, Seth.
Right now, I don't have any questions.
We have a couple. Thank you for that great presentation. Before I take our first question, I'd like to remind everyone that they can submit any other questions into the questions chat panel to the right of their screen, and we will take as many as we can and time allows. And our first question is about how to access the replay. Yes?
Oh, okay. Yeah, then I'll let you answer that.
Okay. Our HFMA chapter will follow up separately with our attendees on that one.
Okay.
So, Seth, our first question is, should a provider append the NCCI modifier to column 1 or column 2 in the PTP file?
Oh, yeah, great question. So I should have that in the presentation. Great question. It goes on the column 2 service to show that it's separate, distinct, appropriately from the comprehensive code. Great question.
Awesome. Another question that came in. Does the OCE edit claim submitted by CAHs?
CHSs?
Yeah.
When you CHS, if somebody, whoever asked that question, I want to make sure you define what
CAH is.
critical access are we talking about?
Yes.
Yeah, so access hospitals are subject to the OCE. Although they may be paid under a different method, their claims are going to be processed through the OCE editor. And that's what we were talking about. Those 7 non-prospective payment system hospitals that have a different payment methodology, such as critical access, Soul Community Hospital, cancer, children's, I'm blanking on what the other 3 are off the top of my head. But yeah, they're still going to be subject to the OCE and to all correct coding initiatives.
Okay. Also, what is the difference between the OCE edits and the NCCI procedure edits?
So another great question. They actually work together. If you fail an NCCI edit, Medicare will actually give you back an OCE edit that will tell you that you failed an NCCI edit and which one. And again, I think the numbers on there are 39 and 40 in the OCE edits are actually indicators of failure of an NCCI edit.
Okay. Those are all the questions right now. Seth, do you have anything to add?
No, those are great questions, and I will try to incorporate some of that into the presentation for the future. If any of the references don't work for any reason, let me know, and I'll make sure that you get an updated link, but the last time I checked them, they were all good. If you have follow-up questions or any suggestions on the improvement of this presentation, but other than that, thank you very much for listening for 40 minutes to what has to be the most painfully titled webinar available from HFMA today, I think anyway. Thank you.
Well, thank you. And as we wrap up, I want to take this time to thank our members in healthcare community for participating in the Medicare Bootcamp webinar series hosted by Region 10 chapters of HFMA. Thank you again so much to our guest speaker, Seth Avery of AppRev, and everybody have a great afternoon.
Thanks.